Hello, I'm Mr. BEDOYA-RONGA, consultant gynecologist specialized in endometriosis. I'd like to thank the British Society of Gynae for selecting our poster and to be able to present #Ancient FEASIBILITY STUDY comparing ultrasound scan and surgical concordance. It's well established that ultrasound scan should be and is recommended to be one of the first investigations for any patient with suspected endometriosis and pelvic pain. This ideally should be a specialized ultrasound scan as the one we provide. Also, the British Society of Gynae has recently introduced new criteria for the accreditation of endometriosis centers. This is based on index cases which fulfill certain degree of complexity as defined by certain #Ancient findings at surgery. Also, it's been demonstrated in multiple studies that there is a very good correlation on findings by ultrasound scan, by MRI and by surgery when utilizing the classification of #Ancient. This opened the door to a common language among sonographers, radiographers, surgeons, common language for MDT, a common language for research, and although it's a bit complex, can be also very useful for counseling, as this classification predicts the complexity of the surgery. At Midland Metropolitan Endometriosis Center, we utilize ultrasound scan as a diagnostic and triage tool for surgical stratification and complexity based on the IDEA consensus and the MUSA consensus. And when we audited our outcomes, our surgical findings against our ultrasound scan findings, we found a high concordance. In view of the coming changes, we wanted to see how accurate is our ultrasound scan when we translate the reports into #Ancient, and how accurate are with the surgical findings. We retrospectively looked at 18 cases and compare the sonographic results with the surgical findings. And we look at the areas which constitute index cases for the British Society of Gynae and the compartments A, B and C. Compartment A being the recto-vaginal space and the area of the torus. Compartment B being the parametria or the uterosacral ligaments, and compartment C being the bowel. So we found that out of 8 cases that we have deep endometriosis on the torus and vaginal area, we only diagnosed 1 on ultrasound scan, which gave us a sensitivity or true positive of only 12 and an accuracy of 61%. When we look at the compartment B, or parametrium, we only found 1 surgical case which was not diagnosed on ultrasound scan, giving us a sensitivity of 0% and a specificity of 100 with an accuracy of 94%. And when looking at the compartment C of the bowel, there were 7 surgical cases, and 6 out of those were diagnosed with ultrasound scan, which gave us a sensitivity or true positive of 86% and a specificity or true negative of 92%, with an accuracy of 83%. We acknowledge that this is a retrospective study and with limited numbers, but it's clear to us that we needed to make changes in the systematic approach of our ultrasound scan and in our reporting. We historically concentrated on localized tenderness, diagnosis of adenomyosis and rectovaginal endometriosis, but we have overlooked specifically looking at the area of the torus and at the uterosacral ligaments, and more laterally into the parametrium. So those are the areas where we need to improve, and we have changed our pro forma, and we starting to pay more attention to this. So in the future we expect to have a more accurate outcomes with the ultrasound scan. Thank you for listening.